techniques.
They should work.
So please.
I think. If not, we can change it. Presentation inside. The folder we had before.
Oh yes.
No, in the morning we had it. In the morning session we had it. BVS presentation. That one.
Some of the questions. Just to set something. Just to check. Here.
Dear colleagues, first I would like to thank the organizing committee and Max Medical for giving me the chance to share our experience with aortic root surgery over the past 8 to 9 years and how we decided to start using the biointegral valve conduit. Indications for aortic root surgery, I think they are clear. Aortic stenosis with aortic aneurysm, dilatation of the aortic annulus with valve regurgitation, and our collective, those two are about 70% of the cases. A special case that we'll go deeper this time is endocarditis with abscess or endocarditis of the prosthetic valve. These are about 10% of our cases. Rare in our region is small aortic annulus with a combined pathology, or aortic dissection to PA, which is also at 20% of our collective. The criteria for indication for operation, therefore we have every week before our TAVI heart team meeting, we have an infecto board where the cardiologists attend as well as all other disciplines. We have patients with severe bacteremia and the possibility of endocarditis, as well as our microbiologists. So we have a common diagnosis and indication for the surgery. What possibilities do we have? First goal would be also always aortic valve reconstruction, leave the native valve. This is often in aortic with endocarditis, it is not possible because the cusps are destroyed. Ventral surgery or mechanical conduits have shown that they have a higher mortality in the case of active endocarditis, so we try to avoid that. The homograft is something in the aortic position, it is outdated. I just mention it for historical reasons. In our clinic, we had a program, that's how we started, aortic root surgery with Ross operations, in the full root with felt reinforcement technique. There I did my thesis in Ross operation versus mechanical valve replacement. We saw a higher stroke rate with the mechanical valves and also a mortality in the mechanical valves. What we kept there is that we wanted to continue in our clinic with a biological solution. We terminated the Ross program in 2014 because of the poor quality of the homografts. We had multiple stenosis in the homographed pulmonary position, so we were not happy with these results. In the following, we had already used freestyle prosthesis from 2011. After terminating the Ross program, we increased the use of freestyle prosthesis, which was a biological solution, but we were not satisfied with the anatomy, with the risk of repeated valve endocarditis. We had rather higher technical complications. In the follow-up, we had cusp sclerosis, and the pressure gradient on the valve started rising. So after having biointegral and freestyle available both for on a 1.5 year, we ended the use of freestyle prosthesis and continued only with the biointegral conduit. This has stayed for the last 4 years our favors the biological solution in Düsseldorf. Until February, we had 203 patients. There you can see that 13 patients of those were under 50 years old, which is quite young for a biological solution. These patients were patients with acute type I dissection and endocarditis, as well as Marfan patients, who we did not expect to have a long life expectancy. We also see that 1/4 of our patients were under 60 years old. We give the option to patients above 50 years old to decide for a biological solution, and we say, should this valve say calcificate in the next years, which we not expect, if you have a 29 biointegral valve, you can implant a Sapien 3 29 millimeters inside. We also had 21 patients with endocarditis. The use of the biointegral former cell high has been shown to be safe. We could confirm that we had no calcification, no dilatation, that we could there's no reactive tissue technique. We could confirm that, and we find it that it is easier to implant than other valves. And we have not seen it, but we believe that this endothelium monolayer develops in the first time. Our follow-up was from our patients. You can see we mainly used the 29 millimeter valve. The pressure gradients were higher than in other biological solutions, but in the follow-up they stayed stable. As in Ross surgery, we saw that if there are a development of gradient, you might mostly see it in the first year. We think that the surgical technique, there we continued on from our Ross surgery. So we think that the fixation of the native commissure and ostia is very important in order not to lose the anatomy. Then we implant the valve with discontinued sutures. In case of endocarditis, you can use bigger needles from the mitral valve surgery. And our goal with this technique is to have oversizing and reduced bleeding in the aortic root. What we also learned is no use of bioglue. That we also learned from the age of our Ross surgery, because it hardens the tissue and can distort the anatomy of the valve. Then for the reimplantation of the coronary ostia, we also commend not using a punch, but taking scissors and opening the holes. And for the adaptation of the right coronary ostium, we fill the conduit with water in order to see better the anatomy. Further, you can use fibrin glue to have a better, if we have some leakage at the stitch points. The length of the conduit allows us to have a complete arch replacement without the Dockrem prosthesis, which we had to use prior. We use for the conduit anastomosis ongoing Prolene. We also use a felt reinforcement around it. Before closing the thorax, we make an off-label use of 1 gram of vancomycin and rinse the thorax. After that, in case of endocarditis, we have 6 weeks of IV antibiotic therapy, 3 weeks in our clinic and 3 weeks in the rehabilitation clinic. And we also insist of 6 weeks at least of anticoagulation for the patients with endocarditis. We have it as long as they are in the clinic with heparin intravenous. For discharge, we give them Marcuma. From our endocarditis collective with 21 patients, we were very satisfied. We had no reoperations and no conduit re-endocarditis. We have not explanted any of the valves until now from these 203, so I have borrowed a picture of a valve after explantation because of endocarditis from Professor Sosnowski, but we expect the same, that there will be no sign. What we have seen in the effector board several times, patients after biointegral implantation were presented to us with bacteremia, but we could not see any signs of endocarditis on the biointegral valve, and also in the PET scan the valve stays negative. It does not show any signs of infection. In summary, we say that the biointegral no-react conduit seems to be optimal for patients with endocarditis and patients with acute type I dissection regardless of age. These patients are in acute situation, so I think that's for the best for the benefit of the surviving. We had reduced bleeding and no reinfection, and we're very satisfied with the adaptation of the anatomy. The implantation technique was easier, oversizing is possible, we had no patient prosthesis mismatch and an optimal hemodynamic performance due to the oversizing. In aortic, if you had aortic replacement was necessary, we had no need for additional Dacron prosthesis, and we saw until now no calcification and no dilatation, and the pressure gradient stayed the same. I think that we think that if the endothelium monolayer develops, the durability should not be any more affected for the future. Thank you very much.
Thank you, Dr. Smiris. Wonderful presentation, wonderful results, great series of patients. The paper is open for the discussion. Do you have any technical difficulties at the beginning of the experience with the conduit?
Yes, to be
Bleeding,
honest,
for example, or not using the bioglue or whatever, some tips and tricks for us who are trying to start the program, yeah.
the not using of the bioglue, we found that out with the ROS patients. We had our learning curve still in the ROS patient group. Yes, at the start, we had some cases where the location of the right coronary ostium was difficult. The solution was quite simple. If we had problems going off cardiopulmonary bypass, we took out a small piece of vein from the leg, and as long you are still in the process, we did, if the patient did not recover until we had the vein out of the vein, we did just a bypass on the right coronary artery.
And what is the trick now to avoid that problem?
It's to get a good feeling how
To have experience,
will not have a
twisted or kinking of the
coronary artery.
Yeah. Okay. Thank you. Please, Professor Obrenović.
Yes, endothelialization is the reason. you could also take only one, but we are surgeons, and if you say 6 weeks of coumarin and then change to aspirin, the possibility that it will be forgotten, and somehow it's better. It's easier. It was easier for the it was easier. Take
So
one aspirin a day for your whole life, and
So it
Marcumar
can be
for
it can be forgotten even in Germany, yeah. not only in Serbia, yeah.
it's just easier. That's the no other reason. We had no problems of bleeding, so we were afraid of the anticoagulation.
Okay, Dr. Smiris, thank you very much. We'll have to move forward due to the sake of the time. So I have a privilege now to invite Professor Igor Medvedev from Rijeka, Croatia. And this is a Medtronic Symposium. So Professor Medvedev, please go ahead.